For this lecture, we're going to look at pain, something we don't usually enjoy, and stress's role or effect on our experience of pain. First, if you look at your outline notes, you'll see one of the very first things that I've mentioned is the fact that pain is actually a very necessary signal in our life. And I'll give you an example. Some of you know that in the last decade, I have managed to break several bones. Not all at once, in 3 separate experiences. So let's say one of those times I broke both bones in my lower leg. That was painful. I didn't want to stand on my leg because I was getting this screaming pain signal. No, don't stand on me. Oh my God, look what you've already done. Don't do any more. This is bad. In other words, it kept me from walking home on it. Trust me, it really kept me from walking home on it and kept me from doing further damage. So in other words, pain motivates us to modify our behavior. And this helps us to reduce the insult, whatever is causing that pain, to try to not make it worse. Let's not do this because this hurts. And it lessens that potential damage to us. So in this sense, pain is actually a mixed blessing. Do we enjoy being in pain? No. Is it important for us to experience pain for our own good sometimes? Yes. Unfortunately, that can become an ongoing chronic situation in which that experience of pain is not really useful to us anymore. So first, let's take a look at the sensation and the perception of pain. First, we have little receptors. We've all been talking about receptors a lot, all through our body. And they send projections to the spinal cord. You can even go in and cut some of these receptors open. And when you do, it releases a flood of chemicals which go into action going, pain, ouch, hurt, pain, ouch, hurt. Anyway, some of these actually carry only the pain information. Others carry information about pain and other everyday sensations. What do I mean by that? Pressure, just pressure. Having pressure in one place, that is a sensation. If I'm pushing here right now, that information is being carried to my spinal cord and then to my brain saying there's pressure there. Itching, vibrations, so on and so forth. These are everyday sensations which are carried, and sometimes if they're very strong sensations, that is going to cause a strong signal. And Sapolsky's words are, sometimes pain consists of everyday sensations writ large, meaning written, communicated in a very large, verbose way. So at the spinal cord, this information is funneled to other specialized pain receptors. Get us going down here. And pain neurons that are specialized know to turn information and send it to different brain areas. For example, some of these specialized pain neurons send information to the cortex, and the cortex is like, oh, something happened. What happened? And where? Okay. Some of the information then goes down to the spinal cord, which goes, ooh, get away, withdraws that body part. Put your hand on a hot stove and it will tell you something. And this information, at first, you may not even realize what is happening, especially if it's not in a planned area like that. All of this then signals the autonomic nervous system. Remember that autonomic nervous system, sympathetic, parasympathetic, activation by the brain. And that says to the hypothalamus, oh my gosh, start releasing corticotropin releasing factor or hormone. And I keep getting angry with myself because I always want to change that to hormone, not Jormone. And I'm probably going to have trouble because this laptop is horrible. Hormone, same thing as factor. You can hear it referred to as either one, CRF or CRH. And that then, what does it do? I kind of skipped a spot here. Want you to fill in this idea that CRH or CRF goes through the pituitary stalk into the anterior pituitary, goes release ACTH, right? ACTH from the pituitary gland. And then that information will go through the circulation to the adrenal glands. And right now we're talking about the adrenal cortex, and prompt the secretion of glucocorticoids, primarily cortisol. All of this comes in such a short time. It does not take long at all for all this to happen. So let's move up a little so I'm not blocking this. So we have modulation of this pain information. Pain information comes via fibers from the periphery to the spinal cord, and these fibers come in different classes. Now, if this were a different course, we would talk about a lot of different subcategories. For the purposes of this course, all I'm asking you to know is that we have fast and slow fibers. We have acute, sharp, sudden pain, ooh, ooh, it's poke, poke, versus that slow, diffusive, constant, throbbing pain. These fibers, the acute is fast, the diffuse is led by slow fibers, carried by slow fibers. And both of these types of fibers project to spinal cord neurons and activate them, but they do so in different ways. So this is where I've thought a lot about this lecture, and I actually put off doing the narration because I'm frustrated. When I'm in the classroom, I have a really cool way of using some of you as demonstration and have you be fast fibers, slow fibers, a Y interneuron that we're going to talk about in a minute in the brain. And try as I might, I could not get my cats nor my dog to participate. So I'm going to do my best with this. Let me take a look with you at this diagram that is in your Zebra book. Remember that ultimately all of this information has to get to the brain. And here are the two kinds of fibers that I'm talking about. The sudden pain, fast fibers. The slow pain, slow fibers. And this little devil right here, this X interneuron, signals pain to the brain. You're like, well, they're both saying pain. That's right. See this positive sign? That means they're both stimulating the X neuron to go, pain. And when you stimulate this X neuron, your brain goes, ow. All right, you're going to be hearing me say that a little bit. Sorry. Anyway, so what makes it different? How is it that they actually have different effects? Well, now we have to look at this little guy. The Y interneuron is our friend, let me tell you. And the interesting thing about this guy is if you activate, stay with me here, the Y interneuron, it will go and look at, it does not stimulate this X pain neuron, it inhibits it, okay? So when you have sudden pain, first, that message goes very quickly this way to the X neuron and then to the brain. It goes, ow! But just momentarily afterwards, it also sends information to this Y interneuron and activates it. This is important, which then the Y interneuron goes and says, stop. So now we have pain, stop. Pain, stop. Okay, you following me? We have excitation, stimulation of X that gives the brain, ow. And then we have stimulation of the Y neuron, which says, stop. Feel pain, turn it off. Feel pain, turn it off. Okay, now let's go down to the slow pain or slow fibers. Again, let's stimulate it. It goes and goes, pain, ow, 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 ow. But look at this. This is the huge difference. Whereas these fast fibers stimulated the Y neuron, which will then stop the pain, the slow pain fibers inhibit it. So guess what? That means the Y neuron cannot turn off the pain signal. And that is the important part of this. We want to stimulate the Y interneuron because that will disrupt the pain signal. So now, instead of having, ow, oh, ow, whew, we have, ow, wow, 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 because we're not getting it turned off, okay? Now, there are lots of feedback situations here. You can see this all gets very, you know, it looks complicated. Actually, it isn't as complicated as it looks. But what I want you to focus on for this course is this right here, letter B. And that is, we're going to see in a few minutes, the difference that that can make in terms of our experience of pain. So right here, clinical implications of this are that we have the ability now to shut down some of that slow, diffuse, chronic pain by stimulating the fast pathway via the Y interneuron manually. Think about it. What is one of the first things, at least most of us do, if you bump yourself? Like, let's say I bump my arm, which happens, and first thing is, oh, ow. And don't you rub it, you press on it? Ha! We're manually stimulating Y interneuron. Yes, it's complex, but think about it just via that diagram. But we've also learned that we can electronically stimulate that same interneuron. Now, some of you may know somebody with type 1 or type 2 diabetes. In type 1, we basically have not enough insulin. Remember, the pancreatic cells aren't producing it, and so we get insufficient energy delivery. In type 2 diabetes, if we're not getting the insulin into the cells still get sick. They still are damaged. And just think, I want this to be like intuitive because then it's like one less thing you have to memorize. If you're running, you're running fast. Are you using more or less energy than if you're like, yeah, just, oh man, nice day out there, strolling? Of course, when you're going fast, you're using more energy. While you're demanding that. What if the energy isn't there? Well, think of that in terms of these nerves. Those nerves that require all of this fast, and we need lots of energy, glucose, glucose, glucose. They are generally the ones that are more damaged from things like diabetes. Now, some of you who do know individuals or an individual with diabetes know that sometimes they get this chronic pain. Initially, usually people think of like in their feet or legs, and it is aching, throbbing, diffuse pain that does not go away. That is ultimately because the fast fibers that have the capability of turning off the pain signal have been damaged because of the lack of energy delivery to them. Okay. Now, sometimes we have pain that goes on longer than it should. Whoops, sorry. And in this case, you have to think about what is going on. If you have an injury that causes days of inflammation, which very often is really the case, there will be extended periods of pain. And that's important too, because this is when there is healing taking place. So it's like, don't get back too soon. Don't damage this anymore. We have inflammation, there's healing going on, and so forth. Sometimes, however, something goes wrong with the pain pathways somewhere between those receptors that are out here in the periphery somewhere and your spine. Now, it's possible to feel pain long after the noxious stimulus has stopped or even after the injury has healed. And we know this is sometimes even in the absence of an injury, what fibromyalgia is turning out to be, just heightened messages from pain receptors that are errant. They shouldn't be happening. Now, in noxious, remember, not think of somebody who is obnoxious, okay? It's like, you want to get away from them. So noxious stimulus is a stimulus you want to get away from. It's disruptive to you. So you feel pain in this case where you have this abnormal communication. You feel pain in response to stimuli that should not be painful. Just rubbing an area like this can feel painful. Pressure here can feel painful, even though it shouldn't. This situation is called allodynia. Allodynia, same old. And that is what we're talking about. That is the situation of feeling pain in response to a normal stimulus. And this can arise from different places, okay? This can be initiated right at the level of the pain receptors. In this case, the pain receptors are just, for some reason, have become more excitable and easily stimulated. So they're like, whoa, 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 oh, ow, whoa, oh, ow, okay? Perfectly healthy tissue in the area will start to hurt as well. And this can occur when neurons in the pain pathway are injured. Also, excuse me, nerve endings that are severed near the pain receptors actually have inflammatory cells that release growth-promoting factors that prompt nerve regeneration. Okay, so nerve endings actually may rewire in like a tangle called a neuroma, which turns out to be hyperexcitable. And now a mere touch, as I was saying before, ouch, oh, ow, okay, is excruciating. I told you to hear me say ow a lot. Oh, ow, ow, ow. Anyway, hard to talk about pain if you never say ouch, right? Insufficient energy can get through the blood vessels. And that's a terrible way of saying that. What I'm trying to say is there's not enough energy that gets through, okay? So then you've got damaged nerves again, okay? So that idea of no pain, no gain, well, let's switch that over a little bit. No brain, no pain. The brain's interpretation of pain can be subjective. After all, it is the brain that interprets what we're experiencing as pain. Okay. And interestingly enough, that there have been now reams of studies that have been done that have shown the way that subjectivity can influence one's feeling, one's mood, one's pain levels, healing, and so on and so forth. One of the more original studies actually showed that if you looked at patients in the hospital who had views of trees from their windows, okay, and you compared them to patients who had just blank walls, those who had views of trees requested less pain med than the other group that did not have that same view. Manipulation, as I put here, of psychological variables, such as a sense of control, actually in these studies altered the quantity of painkillers requested by chronic pain patients. Now, I know some of you have experienced this. If you've been in the hospital and had some kind of procedure, surgery, or whatever, you get that initial anesthesia and then initial, IV injection pain meds. But then you have an IV hooked up to a pain medication pump, which you theoretically have control over. You have a little button, and it's like, well, oh my gosh, I'm feeling a lot more pain right now, so I'm going to release some more pain med. Oh, that feels better. You feel like you have a sense of control, and you only ask for it when allegedly you need it. And I do think that one thing that this particular form of administering pain meds is supposed to do is give you a sense of control. And even if they don't really tell you that, and also they're assuming that you won't ask for pain med unless you really need it. So it won't be delivered automatically. Of course, there's a point where you can push that button as many times as you want, and it's not going to deliver any because you've met your maximum dosage for a period of time. But I just thought I'd mention that. Some of you know exactly what I'm talking about. I have a very crazy down and up key today. Anyway, 3 important factors to think about here. The emotional and interpretive level of pain can be dissociated from the objective amount of pain signal that is actually traveling from the spine up to the brain. So at the point of the spine, the actual pain signal is the same, but it travels to your brain, where it then takes on a more subjective assessment. There are examples in your book that you can easily read, and I forgot, and I apologize for this, to check and make sure that this is the page that in the most recent edition of the Zebra book it's on. Obviously, if you look at the pain chapter and you read it, you're going to see it. I'm going to leave that up to you to take a look at. If it's not on that page, it's somewhere in the chapter. Apologize. And many of you have different editions anyway. I don't ask you to get the absolute most edition. If you know somebody else who has 2 ago or something, that's fine. Anyway, the more emotional parts of the brain basically can also alter how the spinal cord responds to pain information. And sometimes this can result in something that we call hyperalgesia. And this all brings us to stress-induced analgesia. If you are an athlete, you're probably, familiar with this, and it will make sense to you as I talk about it a little bit. This phenomenon was actually first reported during World War II. And that was when stress experienced in the right way actually reduce the perception of pain in humans, and it's done this in other animals as well. We've seen it in soldiers and athletes. One of those deals where you'll be out on the court or the field or whatever you play on, depending on your sport, and you get down, you go down, you get tripped, you get kicked, you fall, get who knows, and it hurts, but you don't know exactly how much until you get off the field and all of a sudden it hits. And soldiers have managed to carry some of their fellow soldiers long distances while they themselves were terribly injured and with very horrible injuries that should put them right down, but they don't even sense that pain at the time because of this phenomenon. We've actually seen situations with like stressed rats and a hot plate test that is actually in your book. There are cases where it depends on how long the stress has gone on, how much you might respond to it. And that is an incredibly important point. Try to read that little section in your book. If there are any questions about it, I can address it on a discussion post when we get close to the exam. But just know, maybe you've experienced this yourself, and let's just put it in our human terms. You have something, you're full of energy, you're playing a sport, you're doing something competitive, you're in an accident and you have to help somebody, you're getting somebody out of a car or pulling somebody out of a ditch, who knows, and you're hurt. For that period of time, you don't feel much pain. But if you had to keep doing that over and over and over and over and over and over again, that stress will ultimately make you even more susceptible to pain signals. So this whole phenomenon, this analgesia, stress-induced analgesia, is basically a concrete brain phenomenon. It's neurochemically based. We can see the differences in the neurochemicals and then reported experience of pain. So let's take a look at this neurochemical basis. First off, all of the opiate drugs, see if I can move this over, I do not like that blue line. Opiate drugs include heroin, morphine, opium, anything like that contains morphine and codeine, various drug derivatives and combinations. They block pain by activating descending pathways that actually blunt activity of that X neuron. Remember the ow, okay? Stimulate, ow, stimulate, ow, okay? So let us block that information here at the level of the X neuron, and then you don't have that experience. Lots of times these drugs also have other effects, including quieting colic, and if you're heard of babies who have colic, and counteract diarrhea, become constipating, which can be good and it could be bad. And so they have antitussive effects. Coughing, anti-coughing. That's why a lot of the cough medicines had initially these actually forms of medications, not heroin, but now they try to use less direct opiate types of drugs. But now this is where I really want to point out a difference, because even out in the public and medical communications and whatever, I hear these terms inappropriately used very frequently. First, we have endogenous, made by ourselves within our body, compounds that are similar to opiates, opiate drugs. Now, when endo is within, and it's making it within us, okay? And we have enkephalins, which are like endorphins, but they're smaller molecules. We have those endorphins we've talked about. Several types exist. The term is really used generically to refer to both a lot of different endorphins and sometimes to the enkephalins too. Every once in a while, I just can't help myself, or both. And dynorphins, which I'm going to talk about in a minute. They are not particularly pleasant. Now, remember this, for a drug to have an effect, for anything external to have an effect, we have to have an endogenous, something within our body receptor that will be activated by it. So even if it doesn't look exactly like what we make ourselves, it's got to look close enough to that our receptor goes, oh, here we go. This is one of my endogenous compounds that relieves pain, okay? And it's because, again, that we have these receptors that will be stimulated, that they even function. So this is something I really want you to note the difference of. An opiate is really essentially an analgesic that's not made by the body, whereas an opioid, think of humanoid, is an analgesic made by the body. And interestingly enough, I don't know how many of you have tried acupuncture. I honestly never have. And I've gotten mixed reports from individuals who have tried it. And sometimes I think it may depend on the type of injury or pain that's being experienced, where that pain is, individual systems and so forth. Because I've heard some people say they went and never helped. I have other people who said, oh my gosh, they don't know what they would have done without acupuncture. But for a long time, it was like, oh yeah, placebo effect. It's all in their minds. Well, first off, pain is in your brain anyway. But so they're like, we're going to prove it. We're absolutely going to prove it. And I'll show you how they did it in a minute. First, analgesics work. Remember how they work, all right? Acupuncture actually has been found to stimulate the release of large quantities of endogenous opioids. Now, endogenous opioids is redundant. I apologize. I'm just trying to make sure I emphasize the difference between opioids and opiates. Now, you've all heard about naloxone. Naloxone is an opiate receptor blocker or antagonist, okay? An antagonist is going to reduce the ability of some molecule, some compound to have an effect in one way or another. In this case, naloxone blocks those receptors that we have in our body for these, so that you are reversing some of the effects of too much. That is depressing respiration. This is the biggest thing. Heroin. People take heroin, take too much. Their respiration is depressed because of the activation of all of these particular receptors. Give naloxone, and along with other things, you're blocking other receptors so that you can't activate any other receptors or depress any more physiology with further endogenous or opiates. And actually, this was found because they gave two different groups of patients acupuncture, and one of the groups they gave, placebo, an injection of saline. The other, they gave an injection of naloxone. Now, remember what I just said about naloxone. And it was really interesting. From what I could tell from these original studies, they were totally anticipating for everybody either go, oh, yes, I feel so much better now, or the same kind of percentage of people reporting positive effects as negative as you would normally see. But then they found something else. Those patients that received the naloxone were reporting no relief from their pain, even though they may have previously had acupuncture and felt relief. So that's when they really started understanding more about how acupuncture even works. So that's a little bit of trivia for you. Actually, not really trivia anymore. So, okay, we've got to get back to stress right now. And the idea that during stress, and again, we're talking within a certain time frame, stress releases opioids, beta endorphins, basically, on activation of that sympathetic nervous system, actually pours beta endorphins. They're released from the pituitary gland, and enkephalins are released from the adrenal gland. And these are mobilized in the spinal cord going, oh, stop feeling so much pain. Oh, stop feeling so much pain. And this is great for that period of time where you have to get away from that bear. This bear is real. You feel the hot breath down your back. You're like, oh my gosh. And I just know he's going to rake me down the back. And oh my gosh, he does. And remember, now you have your blood clotting a little bit more so you don't bleed out while you're still running from the bear. You don't want to be focusing on the pain from that injury. So for the time being, your pain experience is reduced. The sensation is dampened. However, this kind of stress-induced analgesia will not go on forever. I kind of alluded to that a little earlier, and it's a very important point. And if you think back to the very beginning when we were talking about the general adaptation syndrome and the different characteristics of when we experience this situation of, oh my gosh, something's wrong and something's happening, and you have a certain number of things that kick in at that point to help you cope and survive. After a while, there is diminished release of opioids. Remember, those made by your body, those endogenous compounds that relieve pain, block the X neuron from communicating the pain signal. There's diminished release. It is basically like there are some other things that are happening, but ultimately, you just can't keep up with the demand. You've run out. You go to the medicine cabinet, there's no more there. Medicine cabinet happens to be you, happens to be your body. So now, throughout this entire, semester so far, we've refined a little bit the idea that stress can cause disease. We've refined it, and we will have a final refinement of it at the very end of the semester. But we have talked about in previous chapters how these different experiences of pain, ongoing pain, can cause, or stress, stress, chronic stress, extreme stress, can cause systems to go awry and thus open the door for disease. Okay? This seems to be the one exception to the rule that you get sick because the response is damaging. So we don't need to worry about, oh my gosh, I have stress-induced analgesia right now. I sure hope I don't get a disease from this. This is one case where we're not seeing that at all. So this this lecture, I think, was a little shorter and probably a relief to some of you. But I hope that I was able to communicate the most important parts of exactly what is going on in terms of stress and the production of either stress-induced analgesia or ultimately the experience of pain. Also, the idea that you can have abnormal pain signaling that causes allodynia, and that this stress-induced analgesia is good for a period of time, but it does not last forever. And it's important to make sure that you listen to some of these pain signals. They are, in most cases, providing you with an important message. So.